Hello, welcome to this case. I'm Dr. Amr Nawar. I'm an associate professor of cardiology at Cairo University and the director of EP and SQH Oman. This case regarding the concomitant procedure is a one-stop treatment for patients with atrial fibrillation. He is a 70-year-old male with a history of twice episodes of TIA on anticoagulation, and Holter revealed very frequent episodes of atrial fibrillation. And we have discussed with him the option to do a one-stop procedure to prevent further emboli and also treat the atrial fibrillation. So concomitant procedure, in short, is a one-stop procedure where you can do both PVI and LAAC closure without having to do it in a sequential part, saving the patient and coming in for another procedure, cost effective, and also with the streamlined approach can be done in almost 90 minutes in this case. And the patient after the procedure can stop both oral anticoagulations and antiarrhythmics, uh, and hopefully to be arrhythmia free as well. Okay, so first thing is we prepare the Fara drive sheath. We use in this case the Versa Cross wire and the Versa Cross Connect, which saves you the burden of exchanging sheath. So you can do the RF guided transeptal puncture and directly put your ablation catheter to map and ablate using the Faranav catheter. So we just make sure to flush thoroughly the sheath and the dilator. We use conscious sedation for all our patients since quite a long time. We can do this to enable them to tolerate TE and also prevent movement during ablation. Here we put the Versa Cross wire, and we position our sheath at the fossa ovalis. For the concomitant procedure, for the LAA, you need to be inferior posterior, and for the PVI, you need to be mid-septal and slightly anterior. But with the steerable sheath, you can also go safely infra-posterior. Now we across the transeptal, we advance the sheath, and you have to slowly pull the sheath and the dilator to prevent any ear embolism, and do aspiration during that procedure. Once we're done and flushing the sheath, now we're using the Farawave Nav. The Farawave Nav is a catheter that the Farapulse catheter, both flower and basket configurations, as you see here, also has the ability that you can use it as a mapping catheter. So you don't have to use two catheters to do the procedure. We put the catheter, and then you can map with both the basket and the flower. Our approach is that we do one side at a time. So we started with the left side. As you can see here, we are mapping the veins and a little bit of anatomy around the left superior vein and the left inferior vein. Once we do that, we position our catheter in the basket position. One good thing about the Far Nav is that the Far View module is that you can see the field tag of the ablation, so you can plan where you want your lesion to be, not too anterior and not too posterior. As you know, of course, we do two ablations in basket and four in basket and four in flowers. Then you have to rotate each time. The total would be 8 for each vein. Once we're done with the superior, we go to the inferior vein, and they can also note that the PVI signals after the first shot can be eliminated, mostly eliminated. So we finish with the left side. So make sure we have a secure lesion. And one thing about the far view that you use a less and less fluoroscopy. That is good for the patient and you as well, and us as well. and also plan where the lesion should be. And only fluoroscopy, you might be too posterior to anterior and never realize this before the patient gets a further induced arrhythmia, like atrial arrhythmias. You have a small corridor on the left and the posterior wall of the left atrium and small left atria. Once we're done with the 8 lesions in the inferior, we can sometimes give 1 or 2 lesions to the carina region just to make sure we cover the whole ostia and flora. And then we go to the right side. We do the mapping with the Faranav catheter, the superior vein, a little bit volume from the left atrium. And then the left inferior vein. As you can see, the patient is quite stable during the procedure, no movements, um, while he's in conscious sedation. So I think it's a very good option for the tolerance of the patient. Also enables the patient to be discharged even on the same day. So we're doing some volume acquisition. And once we're done, we start with the superior vein. It's almost done. So we're starting with the superior vein. As you can see, there's slight misalignment between the sheath and the catheter, which gives you a little anatomy shift, but you can also correct this easily in the Opal system. And also you can view on the floor just to make sure that you are uh, quite correct the venostian. So we're giving the 8 lesions, 4 in basket and 4 in a flower as usual. And then we move to the inferior vein. The strategy to go to the inferior vein, sometimes you have to go to the left inferior and then rotate in the flower to reach the right inferior vein if the space is too tight, especially if your transeptal puncture is too posterior and infraposterior. But with the help of the flower drive sheath, it makes it easier to move your catheter seat easily. And you can see here that no signals anymore, but you have to make sure that your lesion is complete. So once we're done with the superior and the inferior, you can see that we will do 2 lesions in the carina just to cover the whole um, right side. That will be the last lesion. And then we'll start with the Watchman. First, we go with the Watchman flex drive sheath. You need to flush thoroughly, this is very important. And then using a stiff wire to exchange the verse across the furrow drive sheath with the Watchman flex sheath. Again, you need to slowly remove your sheath. This is speeded up video, but you need to slowly remove your sheath and wires and carefully put the other sheath while doing aspiration when entering the left atrium just to prevent any air embolism. Position of the patient is quite important as well, keeping the head lower a little bit and your valves lower than the level of the heart. Then we do an angiogram using a pigtail to appreciate the anatomy and the sizing of the left atrial appendage. It goes in the fluoro and the TE in all positions just to make sure that you get the proper positioning. One thing is that after ablation, you might get edema of the carina. So you need to do pre-ablation measurements and post-ablation measurements and take the bigger. You need also to upsize your device because later you don't need any leaks. Now it's time to prepare the delivery sheath after choosing the right Watchman size here to make sure that the device is connected. To push it a little bit, and we close the valve. And underwater, I do many times, like 3 or 4 times, tapping on the catheter just to make sure that no more bubbles are there to prevent air embolism. We're moving from smaller to a larger sheath using a 50 cc syringe. We flush the valve first, then we close and we flush the rest of the catheter. Tapping using eye visual to make sure no more bubbles. And then one trick I use a high pressure saline connected to the catheter to be a fluid to fluid connection with the blood, fluid to blood connection. And then we open the high pressure saline, open the valve, and it will be fluid to blood connection. Then you have to position your sheath inside the left atrial appendage. So we push the pigtail, push the sheath, and then remove and put the catheter as has been viewed before. First thing is to align the sheath with the markers. The catheter with the markers. Hear the click, and then slowly you can advance your Watchman to make the flexible. And using the flexible is a safe shape of the device, so you can easily push inside the appendage without fear of any perforation. Once you align with the neck, and you'll show you're okay. With the TE, you do forward pressure for 10 seconds to make sure all the hooks are attached, and then you do a tuck test. Once you're done with that, you pull your sheath a little bit, and then do the fluoro angiogram, make sure everything is sealed. And also we wait for some time and do many TE measurements to make sure, Doppler measurements to make sure there's no leak, and also the good compression ratio. Once we're done, we do a final tuck test to make sure our device is connected and stable, and then we can disconnect the device, and you do a final cine. And this is the final images of the device. You can see no leaks, good compression, and a 3D image of the device inside it. This is 3D TE as well. You can see the device as well seated. For all patients, we use a figure of 8 closure for the sheath. This combined with the conscious sedation enables patient to have a fast recovery, as well as a possible same-day discharge. So the concomitant procedure actually is a shift from the concrete paradigm for the anticoagulation that needs to be continued even after successful ablation. But after the option trial, which was a landmark trial, comparing Watchman, concomitant Watchman and ablation versus oral anticoagulation in patient with atrial fibrillation, and has showed non-inferiority regarding primary efficacy endpoint of all-cause mortality and stroke. The Watchman was non-inferior to continuing oral anticoagulation post implant, and moreover, there is a superiority in primary safety endpoint regarding less and less bleeding in these patients. Our protocol is to give, if the patient has no contraindications, we can give oral anticoagulation for 90 days as a bridging period, and then we do a TE or a CT just to make sure that the device is well seated, no leaks, and then you can safely continue on aspirin for at least 1 year. We go for a lifelong if no contraindication. One thing I need to mention is the anesthesia that we use. We use conscious sedation for all our patients. We have seen that this is quite relieving and quite ensuring for our patients. They have a fast recovery, and some of them can be discharged in the same day. And also with the experience, our anesthesiologists have gained, we are facing less and less map shifts and less patient movements during the procedure. This as well combined with the figure of 8 closure of the sheath, you can have a very, very fast recovery. The last thing I need to emphasize is the prevention of air embolism, as have been seen in many reports that conscious sedation is associated with more air embolism than general anesthesia. Of course, general anesthesia is more, um, it's a relief for the operator because the patient doesn't move, enables you for a fast procedure. But if you use conscious sedation in the right way and you maintain uh, a clear, accessible airway without the patient having to move too much, and no snoring, and keeping the head of the patient in a good position, and using the correct exchange maneuvers, a slow retrieval, slow introduction, aspiration after, during, and after the introduction of the sheath and the catheters, as well as using fluid to fluid connections, and to always submerge the valve under the saline when you're putting the Watchman. This plus can really reduce the burden of the air embolism, and we're facing less and less of these. So hopefully this case was useful. I got all the tips and tricks of doing it in this case in under 90 minutes. The patient right now, he is off anticoagulation. We have done the TE. Uh, Watchman was well sealed, no leaks. And he's off anticoagulation. The right, he had a twice history of embolism. Thank you very much, and hope that was useful.